familiar with the headlines that we are seeing pretty much every week. And it's all to do with workforce shortages. And in radiology specifically, what we've had is over the years an increase in technology, but not necessarily a commensurate increase in the workforce to deal with it all. And it's great for patients because, you know, you could go into hospital now and instead of just having an X-ray and be sent home, you're probably going to have at least half of those tests. But it's not so great for the people on the sitting behind the workstations going, oh, this patient, I now got to report 1, 2, 3, 4, 5 tests, and then I've got to look at it again in about 3 months' time to see how it's changed. And there's about, you know, regularly in our workstate, we've got about 100 radiologists now. We previously had, when we first started in Imperial years and years ago, it might have been about 15. So, you know, you can see what's happening, but we still can't keep up. So that's our challenge. The other challenge is it doesn't happen overnight. I started medical school, I was going to reveal my age, in 1983. Spent 5 years as a medical student. I spent longer because they didn't have the foundation years in that time. So I spent 3 or 4 years as a medical registrar doing diabetes, respiratory medicine, I did my MRCP. And having got all that, they let me in to do radiology training because you need a solid background in medicine before you start interpreting disease and relaying that information knowledgeably to your clinical colleagues. Because otherwise you become a kind of instrument rather than an opinion. And I always say to my colleagues, we are clinical radiologists. We are not technicians. We are doctors first. And we're using the imaging to help patients get the right treatment, get the right diagnosis. So after doing those years of training, doing the exams, you then spend a bit of time doing subspecialty training. And in my case, I spent time doing research, which was a higher degree. And then eventually became a consultant. And that's where the trouble begins. But of course, we would love this, wouldn't we? Just, you know, I could sit down, have a large cup of coffee and let the machine do it all, but it's not happening. It's not happening right now. Maybe in decades to come, it might. But for the moment, we are using AI. We are using it right now. In most hospitals, the machinery will allow you to automate segments and measure nodules in the lungs, all of that sort of thing. That's here and now. We're using that, but there's more that can be done, and I've just sort of taken this, scraped it off the internet, but it's a pretty good summary of what we're likely to be able to do. So this is just large language models in imaging. You can put them through what essentially is database analysis to come up with usable pre-populated clinical documents. So instead of the clinician taking your history, you know, line by line by line and spending half an hour writing, they can be listening to you and populating what's needed that's unique to you from the clinical documentation that they're finding out. So there are things that we can do to improve workflow, of course. Interpretation. Of course, we can have prompts. You know, you're looking at a scan and you know it's a particular condition. Of course, you want to know what are my mental checklists? What should I be looking for in this patient with this condition? So if they've got rectal cancer, have I looked for this? Have I looked for that? So those are the sort of things that are going to improve not just the workflow, but also our accuracy. You can feed this information into an algorithm that's taken the knowledge and evidence base and produce treatment options. Of course, all of those things can happen. So we're already there, but it has to be integrated better and in a smarter fashion for us to use it. And I think what's missing is probably a really big dialogue with the people that need it and that are using it. So the medics. And getting them engaged is one of the challenges, because they're sort of, it's a catch-22. They're in a clinic, there's 40 patients waiting to be seen by midday. They're not going to spend half an hour talking about IT, and that's the problem. But so we need to have some bandwidth to spend some time. When I first started in radiology a long time ago, we would have an afternoon of development time. It was just built into our rotas, not every week, like once every 3 or 4 months. And we would spend that time looking at our machinery and optimizing the protocols. That afternoon saved multiple afternoons in terms of throughput, just investing a bit of time. We've, over the last 15 to 20 years, our work plans, our job plans, and this is why I switched to the university, used to be 7 clinical sessions, 7 direct patient clinical sessions, 3 sessions of thinking time, research, audit, writing, teaching others, thinking about how you can improve your protocols. That's been gone. So we're all on the NHS side, we're all on 9 and 1. So we're working 9 sessions of direct clinical care and 1 session, which is 4 hours, to spend on, yes, I know, recouping, I think. So that, I think, is where we're at. So I suppose one of the solutions is to give the radiologists, give the medics some bandwidth to start thinking about this stuff again, because that is really what's needed if we're to improve things. Nonetheless, there's some exciting discoveries. There's some exciting things going on. The UK has led research in improving the diagnostic capabilities of scanning, and there is technology that will fuse, say, a CT scan or an MR scan, which is what we've got there, to an ultrasound. That's a prostate cancer. The ultrasound doesn't show where the cancer is, but if you overlay the scan onto it, then the technologist or the doctor, whoever's doing the biopsy, can direct themselves accordingly and get a proper sample, and it's not just a sort of shot in the dark. So these are the sort of things that we're using right now, and it's working well. This again is a case use that is on our scanners right now. So if we put a line on a metastasis, it will automatically identify, outline it, measure it, and then we can assess the spread of that metastasis over sequential scans. It's not perfect, but in the majority of cases, it's good enough. But what should we be careful about in AI in medicine? The first one, I think you'll see that this was the first image I showed where we were using AI to outline nodules. But there is this thing called radiomics, which uses the same principle as genomics, in the sense that it's looking at all sorts of things that we can't perceive with our eyes. So it'll be looking at the original source code, the original, not source code, the original data in the image, to look at, say, they've got various coefficients, intravoxel coherence. There's all sorts of what I call mumbo jumbo, but actually produces multiple sets of data like this, and lots of curves and lots of things that you can then, produce a map of the characteristics that are seen within a single pixel of an image, and presume that may have some hidden aspect about the tumor. The problem with that is what we've observed in radiomics is there's lots of activity in this area. It's very easy to do. You can put regions of interest over something, generate data, produce a signature, and the problem, and this is just the huge increase in radiomics papers over the years, the problem is you get this. Nothing actually works in practice because you're overfitting the data. You've got so many data points, of course, you're going to find a pattern. You're going to, but you're not going to be able to replicate that in another person or another machine. And so, to me, when somebody tells me about radiomics, I am highly skeptical in the same way that I'm skeptical at genomics, when there's no hypothesis, there's no understanding of the mechanism, and it's a fishing expedition. Oh, let's see what the signature throws up, and that's what you end up with. absolutely overlapping things. So what's the other thing that we should be careful about? Well, this is a paper from the Lancet, just published very recently, about using AI in breast cancer screening, which on the face of it seems like a really logical approach. What they've discovered was the current practice in breast cancer screening is that you have radiologist 1 who looks at everything, radiologist 2 that looks at the same panel of mammograms, and if they agree that it's normal, they agree it's normal, and it gets passed off as normal. And if one or other disagree, there's a consensus meeting to discuss why one thought it was normal and one didn't. And if both agree that they were abnormal, the patient is recalled. The rates, when you're in screening, the rates of picking up cancer are vanishingly small. They're not the same as when somebody comes with a lump that they present with. It's about 7 per 1,000. So you have to be certain that the screening program is fit for purpose in that you're picking up those 7 out of 1,000 and you're not missing a proportion. What happened with the AI machine is that if you left the AI machine to its own devices, it would pick up 3/4 of what a trained radiologist could do and miss 25%. So that's a non-starter. And it also identified a whole bunch of lesions that the radiologist would have dismissed. But in amongst that bunch of lesions were some cases that went on to become interval cancers. So nothing is 100% on either side. So what do you do with that information? Well, you do a well-conducted study and model the different scenarios. So in one scenario, they used the AI as the second reader, so that if the AI found something that the first reader, which is a human, didn't notice, there would then be a discussion about that with the second human. So there's 3 processes going on here. That actually did save 40% of the radiologist's workload time. So what happened then was that the second radiologist is freed up to look at more mammograms. But that means that they then are only limiting to that 40%. So 60% ends up being double read, as opposed to the 100%. So it's saving about half the time. So those are the sort of things that, if we think about it, we can use. But to think that the imaging can be automated to that degree is perhaps a little bit optimistic. I'm sure that with more and more data and more validation, they will get better. So 15 millimeter lesion is the sort of strength of accuracy. Something smaller than that, the machine's going to miss in all probability. And what we can do is teach the machine the things that it's missed, and gradually it will start to improve. But it's not a bad shot, isn't it? For a first, for one of the, I think it's the second publication in this region, in this topic, and it will definitely improve. So you take those principles, but I think everyone knows in IT, and it's a well-known truth, rubbish in equals rubbish out. So data input is so important. Making sure that your ground truth is accurate is quite key. And I'll sort of talk about some of that now in some examples of my own research, because that's where I think it becomes quite interesting, because we have different ground truths. So if you had 100 radiologists in a room and you asked them about this lymph node, you would get any one of those 6 answers. That is a problem, because if one of those radiologists is feeding the data into the algorithm to train the machines, as it were, it's going to be not right, or it won't be in agreement with somebody else. The reality is, and I'll talk about lymph nodes in a moment, but that's just an illustration of ground truth. So in fact, lymph nodes are a fascinating area for me, certainly, and I think hopefully for everyone around to understand what their role is in cancer. Long ago, in 1932, a pathologist called Cuthbert Jukes, who wasn't so far away from here, was in St Mark's Hospital, which was in East London for a time, in linked to Bartholomew's, not so long ago. He showed that if lymph nodes were seen in a surgical specimen, the chances of the patient surviving was only 7%. It's a shocking number. 93% were dead within 3 years. But this was in 1932, and surgery was literally done with a sort of pull and snatch approach, even by the great St. Mark's surgeons. It was not the surgery we see today. And yet, because of this work and because of the work subsequently, lymph nodes has been a big thing. If anyone's ever encountered oncologists, the first thing they're talking about is lymph nodes. And the problem with lymph nodes is that we see lots of lymph nodes, and some of them can be benign and some of them can be malignant, and they get big or they can be small. And there is no distinct redeeming character of a lymph node that tells us one way or the other. But what was interesting is that when the radiologist is saying the lymph nodes are enlarged, there is a positive improvement in the patient's survival, which is completely counterintuitive to what Jukes was saying. And the research that I'm doing now is getting our heads around that, and also assisting radiologists in learning to report lymph nodes in a totally different way. In other words, if they're multiple and enlarged, it's a good prognostic factor, but actually it's useful to count them. If a patient's got a cancer and they produced a lot of lymph nodes, that's actually a good prognostic factor, and how many they produce is likely, and that's what we're testing in our research, is likely to be something that's a marker for a very strong patient-driven immune response, as a healthy immune response. So blasting those lymph nodes with radiotherapy is going to have the opposite effect to what you want. You want to augment that lymph node response. And I think now as we're entering this next era of research in drugs, we're realizing that actually the drugs that we're using that to just clobber, diminish the tumors may be the wrong way around. It may be better to start to develop drugs that augment a good immune process. If that patient's already producing a good immune process, why don't we augment it? So that's the sort of way that things are going. So the pathologists are now, their heads are turning as well, because if you have lots of enlarged lymph nodes, it's a good prognostic factor. So that was a publication from the pathology group in Germany. And why is that? Why should that be? And the reason is that tumor within a lymph node is presenting an antigen. The antigen is viewed as hostile by the host immune system. The more antigens the tumor produces, the more likely it is that the patient's going to recognize them as foreign bodies and gobble them up and deal with them. The problem with some tumors is they don't produce antigens, they hide. Then there's no lymphatic response, and there is an absence of lymph nodes. So what happens then to patients? What's happening there that we need to understand? Well, the secret is in this image here, which is showing something that we discovered on imaging and was rather neglected by pathologists as a so what. But actually, it is the most important prognostic factor in a patient with colon or rectal cancer. So this is the phenomenon of tumor growing into a vein and forming these, which are not the same as lymph nodes. They're very different. They're kind of, you can see the shape of them. They're spiky, they're following a vessel, they're turning corners. This is extramural venous invasion. And we see it in about just under half of the patients who present to us with rectal cancer and with colon cancer. And when you see that, about half of those patients develop liver metastases or lung metastases. If you turn it the other way around, if you look at the original pathology of patients who have had liver metastases, in 95%, there has been vascular invasion in the primary tumour. Whereas in the lymph nodes, it's a sort of 50-50. So what we have observed is that, firstly, venous invasion is common. Secondly, it is very easily recognised and much more easily recognised on the images than it is on the pathology. The reason being is that we see the anatomy in vivo. We see the veins, we see them as very characteristic structures. So what happens is that when we see something like that, we know that that is a marker for the spread of tumour to the liver. And if we can block that, if we can understand why that happens, and if we can prevent that from happening in patients with tumour, or at least prevent that tumour from getting into the veins in the first place, then we will be reducing the cause of cancer death in patients with bowel cancer. So how should we report this? I think maybe perhaps people in the room can now recognise that there's a lump there, and then behind it are two sort of stringy bits. What are they? They're vessels. So that's a tumour lump growing and interrupting a vessel. That's how easy it is. It shouldn't be beyond the ability of machine learning to recognise tube, lump, tube. It shouldn't be. So that's our next step, is to start to get that information sort of recognised for radiologists, so that they can be alerted to the possibility that this patient has a poor prognostic risk factor. It cannot be a lymph node. The nodule is trapping along a vessel. So by understanding the pathogenesis, we avoid the rubbish in, rubbish out. We're actually looking at something that's meaningful, that we know is prognostically important for the patient's chances of surviving their disease, and we can start to map it and look for it on the scans that we see. The fact that it's being neglected by pathologists means that some of the existing data sets are not readily usable at the moment. So we have to go back and start looking at them again, which is a task that I'm about to embark on. So the other bit of evidence is that the origins of lymph nodes and distant metastases are not the same. So the tumor within a lymph node, you can do its clonal makeup, you can do its profile, a bit like a family tree. And if the tumor in the lymph node has gone to the liver, then the family tree should be the same. They should have the same characteristics. But what we find when we look at these is that the lymph nodes have a totally different profile to the distant metastases. So in other words, tumor is bypassing the lymph nodes to get to the liver metastasis. So in that situation, we are also seeing that the tumor is evading the thing that's going to fight it. It's evading the lymphatic system. How do we make those tumors visible to our first line of defense, the immune system? That's the question, and that's what my research is going to be addressing. So how are we going to do that? First, we've got to identify the tumors. We've got to find the tumors with these tumor deposits, which we can do on imaging much more readily than the pathologists. The next thing we do is, obviously, we've confirmed that the tumor deposits are associated with much worse survival than lymph nodes. Lymph nodes good, tumor deposits bad. And the next thing is to understand what's going on in the biology around those areas of vascular invasion. How is it that that tumor has successfully invaded into a vein and is now on its way to other structures? There's a battle going on, what we call the seed and soil, and that's the hypothesis that I'm developing and working on with colleagues at the Beatson lab at Leeds and at Nijmegen in the Netherlands. And what we are going to want to do is to look at the immune makeup around vascular invasion, around the advancing border of the tumour, to see, and we think this is going to be the thing, that there will be a lack of the tumour infiltrating lymphocytes, the ones that are supposed to battle against the tumour. So all the things coloured in blue are the things that the patient is doing to stop tumour spread, and all the things in red that I've cartooned here are the things that are promoting cancer spread. What we want to do in the future is get more blue and less red. And the way to do that is to identify the things that improve the patient's chances of fighting that vascular invasion. Because our hope is that because only 50% of patients with vascular invasion get liver mets, there must be something going on in the 50% that doesn't, that stops them getting it. What is that, and what can we do for the patients who haven't got that thing? And it's probably immune related, but that's what we need to find out, because there'll be a cascade behind that that's driving that process, and that's what we need to study. And we have to study it uniquely in those tumours where there's EMVI visible on imaging, so that we can use that to prognosticate right at the beginning and get the patients on the correct treatment, because currently what we're doing isn't working. So the trials that we're doing to look at this, with DRIVEN is the big one, it's our flagship trial. We're hoping to get funding for a 1,000-patient imaging pathology study. This will serve multiple purposes. Firstly, nothing has been established like that before. There's no library of imaging lined up against pathology side by side. The histology sections that we will be able to get from that will be able to be looked at in much more detail. We'll be able to do immune staining, immunofluorescence staining. We'll be able to look at the proteins and the genes around the tumour that has been responsible for this kind of devilish spread. Another study we're doing is looking at patients who've developed recurrence to find out if, as we believe, that the route for that recurrence has been through the vascular pathway, and again to study the original tissue to see how we could have prevented those recurrences. We're doing a patient-based study of intensifying surveillance for patients who unfortunately have vascular invasion in their primary tumour to enable earlier detection of that spread and earlier treatment. And then finally, we're mapping those tumour deposits on the sections on the images and handing them over to the pathologist, so that when they're looking at the specimen, they see what we've seen and sample what we've sampled, so that their accuracy improves, because currently they're only picking up 10% of patients with tumour deposits, whereas we're picking up 40%. So that's why that needs to improve. So that's the sort of thing that I hope to do. We're sort of looking for funding to get some pilot work done, but some of the things that we want to do is look at some samples like that, where we batch them and look at the immune profiling, the what we call the chain of events that leads to metastasis. So that's what we're going to be able to do. And the thing is that if you can feed that in to a data set, you will be able to produce a unique profile for patients that are based not just on their imaging, but also on their immune landscape, just from a biopsy, and integrate all of that to a really much better refined prognostic staging system that the patient will be able to get from the biopsy. So the staging, the biopsy, the post-treatment staging, all of those things will be able to really properly, what we mean by properly personalising treatment, and not words. These are how we're going to get there. So these are sort of exciting things that we've noticed just in some very, very preliminary work, which is that the vascular invasion tumours are immune cold. There's hardly any fighting immune cells in and around them compared with the non-vascular invasion tumours. So there is something going on here that we need to get on top of. The other thing we're going to do is, this is work we're doing with St. Mark's, is mapping the lymph nodes and counting them. And that is so painful to do. A radiologist going through each scan, putting a little circle around every single lymph node. That we are in the midst of getting AI machine learning program using NNUnet type software. That is going to be a great tool, we think, because if you can say to a patient automatically, as soon as they've had the scan, you've got 40 lymph nodes. That's an amazing bit of information that you can give to a patient and say, well, your immune response is doing you a favor. Keep doing whatever you're doing, because that bit of you is working well. So yeah, that's what we do. We sort of measuring out these lymph nodes. Another study we're doing, which is in a totally different area, which is patients currently are having a lot of over treatment. They're being put through the mill, radiotherapy, surgery, colostomy bags. And actually, a lot of the patients that we're seeing, thanks to screening, are early stage. Can we identify them? And if we can do so, can we prevent them from having major surgery and just have a local excision instead? So that's the other aspect of what we're doing. And what we've done is we've created a reporting tool. Again, it's going to need eventually large language model processing to produce something that will enable first the machines to link up with the images, but also with a final report. Something that could easily be done, because we're looking not at the vessels and the veins, we're looking at the tumor. Simple question: is there enough muscularis? Is there enough rectal wall preserved around it for a local excision to be performed? So that's what we're going to do. We're going to increase that little green wedge, which is the only patients now with early rectal cancer that get a local excision, to a whole green. And that's what we want to do, so that patients really, if they're going to go to the trouble of putting themselves through screening, they benefit from having been screened to find an early cancer and not be put through some awful torment. And then I think it will encourage patients to come forward, because they'll know that there's a benefit. So there we have the PRESERVE trial, and that, I think, hopefully this is a stepwise UK-wide cluster randomized trial, and we're hoping that within a year or two this will become commonplace. But the other thing is that we're doing a lot of patient questionnaires, and hopefully we can use this tool to improve and streamline the health service for early rectal cancer. So that's our sort of hopes. So I'll just move to there's so much that we can do at each step of the pathway of a patient having rectal cancer, from diagnosis to treatment. And these are the things that we hope to do. So generative language models, reporting tools, workflow and modeling systems, machine learning to aid diagnosis. It's not going to replace the radiologist, but free up their time to do more things, and large data sets to help us with some predictive modeling for individualized risk scores. These are the things that I think will work, and we'll be able to do so within 5 years, really. There's no reason why not, if we could get a little bit of a leg up with some pilot data. But these, I just want to sort of acknowledge all the fellows, the research fellows, who are busy beavering away at all of these projects, and our trial team, and then all the hospitals that have taken part around the country, and that's just the start of things. But thank you very much.